We go to our next speaker, Dr. Vijayaraghavan, who will be speaking on a difficult topic, myocardial remodeling. Dr. Vijayaraghavan is a consultant nuclear medicine in Sri Shankara Cancer Hospital and Research Center, Bengaluru. He has more than 10 years of experience, and his area of interest is nuclear cardiology, pathology, and diagnostics. He is a fellow of American Society of Nuclear Cardiology and a member of ICNM. Dr. Vijayaraghavan.
Thank you very much, sir. Good morning. My topic for today is myocardial remodeling and PET-CT. So, myocardial remodeling is a process by which the modulation of ventricular size, shape, and function happens over a period of time. And this is what we traditionally know. With the radionuclide ventriculography, you can see one on the left side with the normal contractility and then slightly remodeled ventricle in the middle and then a dilated heart. So this is probably a sequence of events that happens over a period of time once the myocardium undergoes a sort of injury or a pressure overload or a volume overload kind of a thing. So the evaluation for which the best investigation modalities that we have is echocardiography, MRI, and then even with RNV, SPECT, and so on. Then why PET? What's the need for this? If 2D echo and 3D echo can be a bedside procedure, and it can give you excellent volumetrics, ejection fraction, and then even MR can do that, why do we need PET is the question. Okay, so even the trials also say that, once the ventricular remodeling happens, the chances of having major adverse cardiac events are pretty high. And that matches with ejection fractions also. The higher the remodeling, the larger the ventricular size, the higher the chances of hospitalization, stroke, coronary artery disease, sudden cardiac death, and so on. So this is one of the patients which I recently did stress. This patient, 57-year-old male, had a myocardial infarction in anterior wall 1 year back. Maybe he also had triple vessel disease. Electively, CABG was done, and he was revived after AMI and myocardial infarction, and CABG was also done. 1 year later, this is a picture of the heart. You can see the ventricular cavity, and then in the middle cine image, and then you can see this cavity size at stress and rest. It's dilated, and ejection fraction has become 30%. Though we have advanced so much in reviving the patients after the MI, they land up in this kind of a phenomenon 6 months or 1 year down the line. So why does this happen and how does this happen is the question. So to understand this, we need to get into the sequence of events that happen after myocardial infarction. This is just an example. The same thing can be extended to any other injury that can happen in the myocardium. So in the first image on top, you can see within 24 hours after severe ischemia, the myofibrils have lost their shape. They've become wavy, and then you can see neutrophils have come in. So neutrophils come in and they start engulfing the debris, and then even if there is any sort of apoptosis happening over there, it try to clear it off by a process called efferocytosis. If efferocytosis does not happen properly, that leads to various other consequences. From 2 to 3 days onwards, the mononuclear cells come in. You can see in the second and the third images, and those cells start activating the fibroblasts. So these mononuclear monocytes and macrophages that come from the spleen, these migratory cells are the ones that are responsible for activating this. So this kind of a trans-activation of fibroblasts lead to production of collagen, and then fibrosis takes place. So the kind of reparative phenomenon that happens once an injury sets in the myocardium is not same across the population. It can vary from individual to individual. So why does this happen in some people? Does this carry any significance? Is something that we need to learn. Though there is not much of data, but this is exciting prospect in the field of nuclear cardiology. So is this just a hypothetical thing that we are talking about? Is there any evidence? This is the proof of the concept. For the last 12 years, there are 4 important trials that we can look at. The first thing was in 2012, this low-dose trial. Someone tried with low-dose colchicine after MI, and they found that the chances of MACE was less in those who received low-dose colchicine after MI. And then a particular fully humanized monoclonal antibody against interleukin 1 beta. See, this interleukin 1 beta is important because um, the point is that once the mononuclear cells come in and they start activating the fibroblasts, the cytokines that they secrete are the transforming growth factor beta and interleukin 1 beta. So these are important for more and more activation of the fibroblasts. So if you block that with monoclonal antibodies, so this is a trial, this CANTOS is a trial which is placebo controlled, randomized trial. So in which they found that patients who received this fared better than those who did not. And then the first Lodoco trial was not placebo controlled. So they went ahead and did Colcott trial. So this Colcott trial was a placebo controlled trial which also showed the same kind of results. So if colchicine can do that, why not something, a broad spectrum anti-inflammatory like methotrexate? That was thought of. So this CIRT trial was done, but methotrexate did not do any good. So this just indicates, these clinical trials just indicate that there is some specific mechanism through which anti-inflammatory agents have to be administered and it should be blocked. So if this is good enough for us to exploit the pathophysiology and then get into the concepts of understanding what actually happens in remodeling process. So this is a Colcott trial, just showing the difference between the placebo and those who received colchicine. So the molecular targets that we have are at cellular level. We saw the process of reparation that happens with the infiltration of neutrophils, macrophages, and then fibroblasts, and then angiogenesis, the laying down of collagen by the fibroblasts, and so on. So we have various motifs, mononuclear cells, they express CXC and CCR motifs, and that can be imaged with ECLI and then pentixafor, and even TSPO for that matter. So we'll look into all these things. So this is one of the trials on the right side. There is an experimental trial in which a rat's LMCA was blocked, and then they tried to administer a hypothetical drug to see whether there will be an improvement or not. So these mononuclear cells, as we know, they peak into the peri-infarct area around 3 days. So the point is that the earlier you intervene, the better will be the prognosis, rather than administering these drugs later on. That's what the trial says. Then TSPO. So TSPO is something that is known in neuroinflammation. It has renewed interest in cardiology as well. So this is a mitochondrial protein that is expressed on inflammatory cells. So in order to understand this, that we need to look at this translational model. So you can see the uptake pattern and biodistribution of ammonia versus the F18 FEDAC, which is a TSPO agent, and then the FTG. So if you see, the biodistribution of FEDAC is pretty good. The target to background is good. There is not much of liver uptake and then lung uptake. But then the point is, even the mitochondria in the myocardium can also have physiological uptake. So though it is such a prospective agent, if we want to use this in cardiac inflammation, we need to combine it with either MR or a perfusion imaging. Now coming to fibroblastic activation. So if there is myofibroblast activation, they start laying down collagen. The first thing that happens is expression of integrins. So this is also a translational model. You can see that in this cut sections, you can see hypoperfused area expressed on the thallium image, and then the fused, the RGD images, and then the cut sections, histopathological sections of that, and then the evidence of immunohistochemistry, and then flow cytometry. These cells that have infiltrated that region actually express CD31, which is an indicator of some sort of an angiogenesis going on. This is an excellent prospect. The point is that, so this integrin expression begins and peaks around 2 to 3 weeks, and then it lasts for about 6 months. If there is a therapy that is directed exactly towards, inducing neovascularization in an injured area, this is an excellent imaging that can be used, and can also be used. The more and more expression of an integrin is an indicator that there will be more and more fibrosis. The more the fibrosis in an area of infarct, there is more of overload on the contralateral. Maybe if it's an anterior wall MI, the lateral wall has to take the burden. Sometimes septum has to take the burden. It starts undergoing eccentric hypertrophy. And then dilatation and then fall in EF, as we saw in one of the cases that I showed. Now coming to FAPI. So we've heard quite a lot about FAPI and its applications in the morning. So FAPI, so in this image, what you can see is once the ischemia sets in, you can see a series of images over there with coronary artery block before PCI, after PCI, and then expression of FAPI, and it can be expressed on a polar map as well, and what has happened down the line. So thing is, the FAPI gets expressed even if there is a severe ischemia. And then its expression, if its expression continues to happen and is more and more laying down of collagen, it's just an indicator that the prognosis can be poorer in these patients. More and more data is coming up on this in various aspects, not necessarily ischemic cardiomyopathy, but also in pulmonary hypertension. So pulmonary hypertension, something that we know of, there's not much a role of PET in this, but then incidentally, if we observe that right ventricle is dilated, or if right ventricular fee wall shows extensive FDG uptake in any of the cases, it just indicates that there is more strain on RV in FDG, I mean. So, and this is what that we know of. But then that is something that we can pick up only after everything has happened. So if we do a FAPI, and if there is an expression of FAPI in the right ventricular free wall, this is an indicator of what could happen later. So evidences are coming up on that, and also on chemotherapeutic agents. Some of the chemotherapeutic agents induce various fibroblastic activation and then LV remodeling and so on, and also in hypertrophic cardiomyopathy. So you can see there is concentric LVH caused by aortic stenosis on the left side, and then the subaortic stenosis, which is a clinical entity caused by hypertrophic obstructive cardiomyopathy. So traditional understanding is that if there is a case of hypertrophic cardiomyopathy due to some genetic factors, it starts hypertrophy, and then over a period of time there will be laying down of collagen, which may be haphazard, we do not know, and then it goes into failure. That's what it is. The problem with these cases is that they can present with syncope, angina, and then even dyspnea, and sudden cardiac death can happen. So we would have heard many stories that celebrity was on treadmill, suddenly fell down and lost life, and so on. So the point is that it's not a sequential event. Evidences are popping up saying that fibroblast activation and fibrosis is an independent process in the hypertrophic cardiomyopathy, and hypertrophy as such is an independent process. So if we do a FAPI image, there are evidences you can see in this picture. There is MR images, FAPI uptake over there. So what happens over here is the amount of fibroblastic activation has a direct relationship with the chances of having sudden cardiac death, so which has been proven in this. So the sudden cardiac death index score directly correlates with the amount of FAPI that is expressed. So our understanding of the molecular basis of remodeling is changing. We are moving on from perfusion only, quantifications only, to what could happen to a patient even if he is revived of a serious myocardial infarction down the line. How should we handle them? Can we harmonize these targets and then sort of introduce a pseudo-theranostic potential of nuclear cardiology is something that we can think of. In the sense, you tell the patient, you tell the cardiologist that this is a patient who is having the higher chance of going into remodeling later on, rather than telling that MR may pick it up, but it can pick up these fibrosis and changes only later on. So we can predict well in time, and this is one of the excellent, exciting prospects of nuclear cardiology. So thank you very much for your patient listening.